Good morning, everybody. Happy Monday.
Morning, Michelle.
Morning. Morning, Dee. All right, let's see how many folks. Looks like we've got pretty good representation today. All right. Welcome. Hopefully everyone's having a great summer, great July. We got a pretty full agenda today. So just want to welcome everybody. Hopefully everyone had a chance to approve the minute or review the minutes, that Gabby sent out last week. Do we have any changes or adjustments for the minutes?
I moved to
If not,
approve, Michelle.
go ahead. Thank you. If not, can I go ahead and get a motion for approval?
So moved.
Can I get a second?
Second.
Thanks, Becky. All right, Liz, I hand it over to you.
Thanks, Michelle. Good morning, everyone. We have Dr. Ashley this morning who's going to present. I wanted to give him enough time, so I don't know if he's made it back to his office yet. I might need to go grab my phone. I'll go through a couple updates while we're waiting for him to join. Just a few updates. First, and probably most important, is in response to the ACS trauma system consultative visit that we had. If you read the report, there were several high-level items that were still on the report that were on the 2009 report, and some of those things will require some leadership collaboration between DPH and the Georgia Trauma Commission. So we just recently formed what we're calling the Trauma System Executive Leadership Committee, which consists of Dr. Ashley, myself from the commission, as well as Xavier Crockett, who's the Health Protection Division Director at DPH, as well as April Moss, who's the Systems of Care Deputy Director, and Michael Johnson, who's the Director for Office of EMS and Trauma. So we are coming up with sort of what we're calling the constitution for the state, as it will be known for the trauma system, and do a crosswalk of, we're not going to have one lead agency. I think the ACS was really trying to jam that round peg in the square hole. So it's our job to kind of make sure that everybody understands what each agency's function is. And certainly that didn't come across with much clarity at the visit. So that's really our big task. And then Dr. Bolger from University of Washington, who some of you may have heard of. She has the Bolger Research Group. She is the current, I believe, AAST chair. She was the past chair of the ACS-COT, and she's a paramedic by background and is a trauma surgeon and the chief of trauma and medical director at UW, has a real interest in pre-hospital research, and we are contracting with her to try to help figure out, bring some research to this pre-hospital space and have some data to drive some of the asks. So we're really excited about that. And then we are a little too early to unveil it to you at this moment, but we're starting to assemble the bones of what will be the Georgia Trauma System dashboard. So many of you in your facilities, for your quality department, and hopefully your trauma program has one, a dashboard that kind of looks at everything from outcomes to process measures to financials. And we're doing that for the state so that we can have everything on one nice, tidy Excel spreadsheet in a red, yellow, green format, so you can understand, are we doing good on this? Are we doing, terrible on this? Where do we need to focus? So we'll be hopefully unveiling a preliminary version of that. Talked about it at the EMS committee, got some feedback, so we're changing up some things on that, and I'll be excited to share that with you. So with that, those are all the updates that I had. Michelle, don't know if Dr. Ashley was able to join yet.
Sure, great, thanks. Oh, go ahead, Dr. Sorry. Good morning, Dr. Ashley.
Hey,
take it away, sir.
Can you see me?
Yes, sir.
Okay.
And I've got your slides up for you, Dr. Ashley.
All righty. You want to go to slideshow then, Liz?
I don't know if it'll work on slideshow. We'll try it, but we are,
All right. They're pretty big, so we can.
there you go. Okay,
Will that
it looks
work?
like it's working. Can everybody see it? Yeah, okay.
Yes.
Okay. I think I'll have to let you advance the slides, Liz, I guess.
Yeah,
Thanks, Michelle, for letting me speak today and give me some time before the committee. Thanks for organizing the call. What this is about, there's a lot of slides here. I'm going to move through this, but we need your input. And this is really, we think that we're ready to go for additional funding. We can't do it if we don't have the support of this committee. This is a very important committee for funding for our trauma centers going to the legislature. And so what you're going to, this is really a discovery meeting. You're going to see some nice slides, but that doesn't mean they're written in stone. Liz, Regina, and myself sort of hunkered down one day and went back through about 10, 15 years worth of data and sort of came up with some ideas. And that's what they are. So we sort of tested this with a couple of government affairs folks to say, what's your political thoughts? And we sort of, incorporated that in here. But really what today is I'm going to give the talk, but what we need is feedback from you. This is really a working meeting, a discovery meeting. There's way too many slides when we go for an ask for funding. These will be weeded down to where we can use sound bites and small tidbits with legislators to get the information across. But we want to be a little bit verbose and a little bit overkill today so that you can see data and you can make comment. So please, if you agree that it's time to go for additional funding for the centers, that's what we need to know today. And if you have a different way of doing it than what we're sort of suggesting here, now's the time to speak up and say, I would try this or I wouldn't try this. So really, this is not a done deal. This is we're really coming to you for your input. We've just got the ball rolling. So next slide. What we found at the Capitol, it works well to always lead with a patient. So pretty much anytime Liz and I are on the Hill now talking, we always try to bring a patient story. The legislators like it, and it helps them understand what we actually do and not just see a bunch of numbers. So one of the stories that we presented last time we were there was the 18-year-old on a motorcycle weeks away from his high school graduation, went down coming around a curve in a highway. 911 ambulance transports to a level 2 trauma center, didn't go to the local nearby non-trauma centers. They realized this patient had severe injuries and needed to be in surgery quickly, and went to the level 2 trauma center and was in the OR within 32 minutes and had a great outcome. This just shows it just so happens. This was presented. This is Northeast Georgia patient, and it just so happened this was presented at their trauma symposium. It's all public, and it just so happens that the boy that went down the truck that was oncoming actually had a video cam for some reason. I don't remember why there was a video cam going, but you can see the boy coming down. This is live shot. The truck is about to run over him. It actually did run over him. The driver could not avoid the patient. And then you see in the top picture, after the truck has run over him and has gone by him, pulls over, and through the rear cam, you can see an 18-wheeler headed for the boy that's laying in the middle of the road. Fortunately, the 18-wheeler missed him, and he did not get hit a second time. Next slide. And you can see after multiple operations, I think it was in the teens, and a significant stay in the ICU and in the hospital in the trauma center, the boy on the left is attending orientation at University of Georgia. So this is really what we do and why we do it and why we're here. Again, we always want to put the patient first and present a story and tell why all these dollar signs mean something, all these metrics mean something. Really, that's boring. But when it comes down to where the rubber meets the road. It's really about getting folks back to their life that trauma has tried to snatch it away from. Next slide. And I know you all know this, but again, when we talk to legislators, we like to educate them about what the trauma team and what a trauma center is. There's tremendous, and we still battle this on a daily basis. An ER is not a trauma center. Urgent care is not a trauma center. A trauma center is made up of that spoke and wheel that you see there with the team approach. Much like you see on the right of the slide, the trauma team is compared, I always compare it to a NASCAR team because legislators tend to understand what that means. And you can see a rapid response NASCAR team. Everyone has a job. They change the tire, clean the windshield, put gas in the tank in just a few seconds. And that's really what we do. And that's the difference between trauma centers and emergency rooms. So you can't overstate that and say that enough when you're talking to the governor or to the legislators. Next slide. And this just breaks it down a little more about, the difference between an emergency room and a trauma center. I really won't go too much into that as I'm sort of preaching to the choir. This is more for lay folks. Next slide. Liz, in the interest of time, I think I'm going to skip this one. I got a lot of talks about going into various areas of the state, but we'll come back to that. But basically, we've been very successful, and we want to promote this story through Dr. Prack's analysis that we started back many years ago. Remember, he looked at the Georgia discharge database, used some sophisticated ICD-9 at that time scoring and compared it with ISS scoring, which non-trauma centers don't have ISS scoring, and basically was able to categorize injuries into severely injured, all trauma patients, severely injured, moderately injured, and mildly injured. And you can see based on that, we came up with our top 5 list of where most of the trauma patients that were in Georgia not going to trauma centers, what non-trauma centers were they in? And you see there in the first column, Northeast Georgia Medical Center was really number 1 as far as volume and severity. And we use this as a roadmap to sort of recruit and go after centers to fill gaps. And we've been very successful. You can see Northeast Georgia became a state designated level 2 center in 2013, and now has become ACS verified and actually gone from a 2 to a 1 just recently. So this is a huge success story by using science and looking at our gaps to recruit centers to come into the appropriate area. I'm happy to say that South Georgia Medical Center, that's down in Valdosta. They were big players in the system, but not a trauma center. And they've stepped up to the plate and gone through the designation process and just completed their state designation really just about a month or so ago. And Phoebe Putney, another major player, has been working very hard, recruiting staff, putting all the pieces in place, and has gone through their ACS consultative visit, and they're pursuing designation. So this is really showing that we've gone after centers that actually are seeing a lot of trauma patients, but are non-trauma centers. Next slide. This is just sort of a historic slide. I won't go through everything, but if somebody asks what's happened over the last decade or so, you can see trauma centers withdrawing from the Georgia trauma system in the far left, trauma centers downgrading in the middle, and then trauma centers withdrawing. You can see to the far right there. So we sort of have this in as a historic slide in case legislators ask, what's happened, because people come and go in the trauma system. Next slide. I think this caught us all off guard. Even we see a lot of movement in the in rural Georgia, but and in the 3s and 4s. But it just shows that even in the urban areas, without funding, we're not ironclad, and we have to watch our flank even in the urban areas. I think AMC coming out of the system caught us all off guard, and we need really to make sure all our trauma centers are stabilized. Next slide. We've looked at access over the last decade or two, and you can see when we started, when the commission was formed in 7, 2007, around 2008, 2009, we were running about 64% of critically injured patients making it to a designated trauma center. A lot of them were being treated in non-trauma centers. And through education, through recruitment, increasing the number of trauma centers, and all the things that we've been doing for the last several years, you can see that number has steadily climbed to where now in 2020, our last set of data, we just got the analysis, we're up to 93% of severely injured patients making it to a designated trauma center. So this is a huge success story. We need to take credit for it. We've done well with the money that's been given to us as trauma centers and as a trauma system. We're making a big impact. And we also know from our previously studied data, published data, that if you have a critically injured patient that's treated at a Georgia designated trauma center for matched injuries versus non-trauma centers, that the survival rate is about 10% improvement. So we've done well with educating, getting patients to the right center, making sure that our centers, we've increased the number. So we save lives, we've increased our access, and now we have a study. We'll continue to work on how long does it take us to get them there, or what we call time to definitive care. Next slide. And this just breaks it down into different patient populations. You can see the far left is the pediatric group, and you see in the sort of, not sure what color that is, maybe a tealish color. In 2003, we were at about 89% of severely injured patients getting to a pediatric trauma center. And over 2010, 2016, 2020, we've pegged that up another 10% or so. We're up in the high 90s, almost 100%. So we're doing well in the pediatric population. For the NE adult, that's non-elderly adult, you can see we've increased over the years as well. And we're up to 97% now. And then even in the elderly, which has always been sort of the lowest group, we struggle getting to trauma centers, and there's a lot of various reasons for that. But you can see we've made significant improvement there. So we're serving all patient populations with our trauma system. Next slide. So now let's dive into trauma. That's sort of an introduction. Dive into trauma center financial drivers. We're going to look at readiness costs and uncompensated care. And the reason we're doing that is because Senate Bill 60 says that we should do that. That's our Bible, if you will. And or as Liz likes to call it now in code 3111-102. So I like Senate Bill 60 because it's easier to say. Next slide. Okay, so what are trauma center readiness costs? When you go to the Capitol, they don't always know the difference between readiness costs and uncompensated care. So readiness costs, as you know, are costs that are incurred by the trauma center to be ready to provide trauma care 24/7. It's cost to maintain essential infrastructure in compliance with the ACS's 2022 Resources for Optimal Care of the Injured Patient, or the Gray Book. You see pictured there on the right. So the things that we have to have as trauma centers before we see the first patient. That's what we're talking about with readiness costs. Next slide. And we've published in this as well, and really have developed very sophisticated surveys that you all are well aware of because you fill these out. They're audited in the sense they're reviewed by our third-party financial consultant, which I do not know. I do not see individual. The commission does not see individual centers. That's your data, but it is aggregated and it is scrubbed, if you will, by the financial consultant. So our data, I think, is very strong as far as, and very conservative for survey data. And you can see our most recently published paper there in 2018. Level 1 centers, the average readiness cost is $10 million for a 1 and $4.9 million, or we'll just round it off to $5 million for a 2. Clinical medical staff for both groups are the most significant cost, and then education and outreach are the lowest cost. Not necessarily because they're low cost, but just simply trauma centers, they don't report a lot of costs in that because they simply don't have funding. So that's an area that we need to target in the future to get more funding for, is education and outreach. Next slide. We've now come a long way to where we actually have level 3 and level 4 data. This is the only data that we are aware of in the country. It's received tremendous inquiry as people want to know, as well as the level 1 and level 2 publications. But you can see level 3s there, the average is about 1.7 million, and the level 4s are about 81,000. Now, we think this is our first time surveying the level 3s and level 4s, which, as you know, and if you're on a 1 or a 2, it's not easy. These are very conservative numbers. We expect these to go up on the next survey as we get more sophisticated or learn to do it. We had to tweak the survey model, or survey, if you will, to fit all the needs of the level 3s and level 4s. But again, it's the only data that out there. It's very conservative, and it's something that we can really talk about. Next slide. So what does that look like now? Percent of trauma center readiness costs reimbursed for the 1s and the 2s from 2008 to 16. You see in 2008, when Sonny Perdue, the commission was formed in 2007, and with all the trauma centers threatening to drop out of the system, Governor Perdue did a one-time infusion of money at 58.9 million. And that's when we went to work and came up with some formulas and did some things, but it was a one-time funding source. And you see, reading across the page, the level 1 and 2 combined readiness cost at that time, with the best survey data we had, which wasn't great, it wasn't sophisticated like we are now. We were just getting started, a lot of estimations. It was only $40 million, which that was woefully underestimated, but it was the best we could do. And you see, in that time, we put in $23 million into the readiness funding, and we were able to fund trauma centers, if you do the math there, at about 58%. So not too bad. I mean, this was probably where we needed to be. We always thought we should be somewhere between 80 and $100 million for the system. And you can see if we were holding at 58%, that's not bad for readiness cost funding, at least in my opinion. If you're an administrator, you may say, well, that needs to be 80 or 90%. So it's all how you look at it. And then you can see from 10 to 16, our funding fell off because then all we had was super speeder that kicked in. And we've been running anywhere from 16 to 23 million, which if you look at the far right, next, the last column, you can see that puts us somewhere between $7 and $4 million of money, which makes it, our readiness costs now are down around 9%. We're refunding you, the commission, which is the money we get from the legislature, we're refunding you about 9 cents on the dollar for your readiness costs. Next slide. And you can just follow that through 17 through 23. I won't read the whole thing, but I will focus you on 23 down at the bottom because it's our most recent data. You can see our commission budget was 22.9 million. We had 5 level 1s, 8 level 2s. I'm just showing the 1s and 2s right now. Our level 1 and 2 readiness costs, putting all the 1s and 2s together, with our latest, most sophisticated, most conservative survey, is $109 million. Okay, that's what putting all the 1s and 2s together. And obviously, as you increase the number of 1s and 2s, that number goes up, and that's why over the years this number has increased, as well as we've gotten better at really tackling what the true costs are. And you can see, so at 109 million readiness cost, we're reimbursing 7.7 million, or about 7 cents on the dollar. Next slide. If now that we finally have level 3 and level 4 data, again, you see our budget is about 22 million. You see the numbers of 3s and 4s there. I'm reading from the line 2023. You can see their costs through the survey for all the 3s and 4s are about 14 million. We dramatically, if you looked at the second to the last column on the right, you can see we've really increased their funding over the last few years, from 19 to 23, from 264,000 all the way up to 800,000. So basically just over tripled their funding, but it's still only 6% on the dollar. So as I look at these numbers, I just feel like we're doing a pretty good job for the state. If I'm wearing my trauma center hat here, we're we're providing great care, and I'm going to show you that we're saving lives. We're doing a good job. We've increased access. We've increased the number of trauma centers with the funding we have, but 6 cents on the dollar, I think we've maxed out. And as we bring more centers into the system, we can't go any lower. I think we could all agree that maybe we don't know what the number is. I've got some suggestions at the end, but 6%, I think we can all agree is too low. Next slide. And this just shows you graphically what that looks like. So you can see in the million on the y-axis, those are millions. And you can see each time we do a survey, you know, they're a few years apart. You can see we've done 3 surveys. The first one was, I hate to call it a survey because it was really very simplistic, but it was the best we had when we started in 2007, 2009. But you can see how the readiness costs have gone up each time we've done the survey. They're up to 109 million now for all the level 1s and level 2s. And you can see our funding is dramatically low and has stayed pretty frozen down there at the orange line at the bottom. Next slide. Now, if we look at the level 3s and 4s, again, you see the huge gap. They're up around 14 million in costs, and we're under $1 million for all of them. So something has to be done here. Next slide. Okay, and this just shows you now if we put everybody together, the 1s, 2s, 3s, and 4s, you see here our budget in the second column is about 22.9 million in 23. We're up total readiness cost, everybody add together about 123 million. We've got about 8.5 million to put in the bucket. So you're seeing the theme, everybody together. Again, we're about at 7 cents on the dollar. Next slide. Okay, now what about performance-based payment program? We want to emphasize this because when I talk to legislators and what I think we need to do, we're not a bank. You know, people are not just showing up and we give them a lot of money just because we think they deserve a lot of money. The message we want to get across is that we're very conservative with our calculations. We do a good job with the money that we've been given, and we're good stewards of the money. And next slide. Our pay for performance-based system shows that. And this was met with positive results from the people we floated this to in the government affairs. It falls basically into 3 domains, whether it's system participation, meeting the criteria in the ACS book, or our Georgia Quality Improvement Program, participating in quality. And next slide. As you can see, when we first started this program, and you've lived through this, you've turned in your pay for performance, you've received your readiness costs. Some of you have been dinged. I got dinged 1 year because I didn't show up at all the meetings. So my trauma center took a hit because, you know, we didn't get all our readiness cost funding that 1 year because we were stretched too thin. But we made some corrections and we fixed that problem, and we're all okay at my center now. So, but it just shows that everybody is held accountable. And you can see the number of pay for performance criteria. In 2010, there was only 3. We've increased that up to 22 metrics now that your money is at risk for your readiness. So we can tell the legislators and the governor, we don't just throw out money. You have to be accountable and you have to meet the metrics, and then you get your readiness funding. Next slide. And this just shows you as over time, we only had 10% of your readiness funding at risk. Now we're up to 76%. So, and the trauma centers are doing a great job. Most every year, most centers hit the mark. Every now and then there's a few centers that don't, and that money goes back in the pool. And guess what? The centers that had 100% compliance, we distribute that money out across them. So we are really accountability oriented. Next slide. Now, uncompensated care. The next slide. This is mind-boggling, is the best way to put it. And so you can see if we use 2008, our total cost of uncompensated care, actually the second column, 2008, second column, number of uncompensated care claims were up just over 3,000. What that means is that by Senate Bill 60, if you don't have insurance, if you don't qualify for Medicaid, Medicare, well, so on and so forth, and you're on the state trauma registry, you qualify. So that's why you may think, well, should be a lot more claims in that, but it's very restricted. Okay. So it's not every trauma patient that you see, you can submit for a claim, as you well know, if you're down in the weeds with that. The total cost of uncompensated care committed at that time was 38 million. We actually had 23 million in that account in our silo for that, because we had, a good funding that year at about $60 million from Governor Perdue. And we were able to fund 61% of your uncompensated care claims. Next slide, Liz. Let's just jump ahead, if I remember. Yeah. So let's look down at 2023 now. There was about 5,594 claims. So as the number of trauma centers have gone up, the claims have gone up. The total cost of uncompensated care has now jumped to 73 million. That's the claims that you submitted. We're able to put $7 million in that silo. That's what we have available for uncompensated care. And you can see when you do the math, that's about 10 cents on the dollar. So remember, 7-8% of readiness cost funding, 10 cents on the dollar for uncompensated care. These are pretty low numbers. It's going to get even lower. Wait till you see this slide. Okay, now let's look at 2024. Okay. One thing that we're continuing to preach here is fairness and being conservative and being able to stand behind our data. And I think you can all agree, and I can, with a good conscience, present this to anybody in the legislature and say that our data is not overinflated. And here's one reason why. In 2024, where there was 5,376 claims, we submitted $659 million in charges, okay, for those claims. And remember, these are only claims that are trauma patients on the trauma registry, which means they have to be admitted for 24 hours. No insurance at all. These are not, well, Medicare didn't pay everything, so we're going to submit a claim. No, if they had Medicaid, they're kicked out. If they had Medicare, they're kicked out. If they had car insurance, they're supposed to be kicked out. So $659 million in charges. Now, you could say, so how did we get to total allowable charges of uncompensated care claims down to 70 million? So I'm going to put my insurance hat on here a little bit and talk like Medicare and what about allowable charges. The equation that goes into uncompensated care for those patients that qualify, they go through a metric, and obviously your trauma center turns this data in. So the volume of trauma patients that you have, we look at that. The ISS score, how severely injured they are, we look at that. So is it 0 to 8, 9 to 16, 16 to 24, greater than 24? We look at the number of patients in each silo. That way, one trauma center says, well, all my patients are super sick, I deserve a lot more money. And another trauma center has all patients with minor injuries, probably doesn't deserve the same amount of money as the one that has people that are in the hospital for 2 months that are all crunched up. So the equation actually allows for that, and I could spend time go through all that, but I won't today. But I ask questions, answer questions if you have them. So we actually know, we break it down on severity. And then back at the time when we developed these formulas years ago, we had some proprietary data from Bishop and Associates that we knew national cost norms for a patient 0 to 8, 9 to 16, and so on. And I'm just going to make up some numbers. I'm sort of close here, but for 0 to 8, it's $5,876 or something like that. For 9 to 16, I think it's $13,000 or something. So we basically had some numbers. Those numbers are grossly outdated. They're so old, they're over 10 years old, but they are a marker and they do plug it in. And we never have enough money and we don't have enough funding to give you all your uncompensated care anyway. So it makes us a standardized way to make sure no one games the system with just specific charges. And so when you multiply all that out, you come up with what your trauma center charges are worth or allowed, if you will. And that's how we go from 659 million down to $70 million. So these are very tight and very defensible. Okay, you could easily say, and I can support you, and say $70 million is too low. That's true, but we're never going to have 659 million. So it's sort of a wash in a way. But anyway, working through the slide here, we're down to $70 million that are a 90% deduction, if you will, in what you've submitted. We only have 6.7 million, if you're reading across the slide here, $6.7 million to put in that bucket. So that's 10%. 6.7 is about 10% of your 70 million. So we're reimbursing 10% of your uncompensated care. And if you look at the actual charges you submitted, we're only reimbursing 1%. So I think however you want to look at that, that's not enough funding for trauma centers. We are low. And that's the idea of this exercise, is to show the legislators we are underfunded. Next slide. So if you just sort of graph that out with uncompensated care like we did readiness costs, you can see uncompensated care has gone up over the years. Our uncompensated care funding has been held consistent or stable or leveled. Next slide. And you can see our percent of uncompensated care cost funding has gone down from the whopping 61% when we had that one-time infusion from Governor Perdue, all the way down now to about 10% or less. Next slide. So what's it all look like? So total trauma center costs with readiness costs, we're pretty comfortable in saying I believe it can be more, but I'm very comfortable in saying that level 1s and 2s, it's 109 million total. For level 3s and 4s, it's 14 million. So total readiness costs for the state of the designated or verified trauma center are 123, almost $124 million. Submitted charges are 659 million for uncompensated care. The allowable charges through the commission's formula is 70 million. So if we take the 70 and 123, we come up with a total package that's very defendable of $194 million where we are today. Next slide. So to close out here, we've been trying to build the case that we've done a good job with increasing trauma centers, increasing access, increasing quality, having accountability in our funding and our performance-based payment program, and that we've done all we can with what we've been given. So has it made a difference with injury mortality? And it actually has. This is sort of I think a big deal. Age-adjusted injury-related death rate. Now, if you look to the far left, this is from the CDC website or the Whiskers data you see at the bottom of the slide. You can see the United States in 2003 was somewhere around, I think 50, if you look at the actual number, somewhere around 56 or so risk-adjusted mortality per 100,000 patients, okay? You can see Georgia in orange, we were up around, that's about 66. The southern region was about 66. So we were above the national average with our age-adjusted injury death rate. And if you remember the cry back at that time, around 2007, if we could just get to average, if we could just get to the national average, that would translate into saving 700 Georgian lives per year from trauma. If we could just be average. And that was our battle cry. And that's part of the reason the commission was formed. That's part of the reason we got the 60 million from Governor Perdue. They finally heard everybody's cry. It was a state effort, everybody working together. So if you look over time, you look up into 2019 now, you can see overall in the United States, I'm not sure why you'll ask me, I don't have an answer yet. This is off the CDC website. We're trying to dive into this and get some more answers and get some epidemiologists on it from the state. But in general, the age-adjusted injury death rate in 2011 started going up in the United States as well as Southeast region, as well as Georgia. But look at the main take-home message here. If you look at the United States death rate in that sort of teal color, they're up to about 76 or so deaths per 100,000. The southern region is even higher, But if you look at Georgia, we are below the national average finally, after all this work over the last 10, 15 years, and we're below the Southeast region. Georgia is making a difference. We're doing something. We're on the right track. And so, you know, this is a good take home message. You know, well, we've gone from above the national average to below, but we've maxed out our resources. Next slide. And this next slide. And this just shows you there, the bar graphs to put the actual numbers. You can see again, the far right in 2019. This is about as far back as we could go the other day, I think 19 or 20. 76 per 100,000 national, and you can see we're better than that, and we're better than the Southeast region. So next slide, I'm just about done here. So what our proposal with all this, and again, this is too much. I understand it. You're probably tired of listening to me talk, but we're just trying to give you all the data points you need to make an informed decision and to make comment. Obviously, when we go to the legislature, this will be much more streamlined and shorter. So if you look here, this is a busy slide, but if you look at the far left, our 1s, 2s, 3s, and 4s, trauma centers, we've got in the second column, the number of trauma centers. In the third column, we've got their average readiness cost, 10 million for a 1, 4.9 million for a 2, 1.7 for a 3, and 81,000 for a 4. You see the total readiness cost for all those added together comes out to be about $122 million in the 1, 2, 3, 4th column. What we're proposing, you know, what is the number? This is where we need to have a discussion. What's the number? I know 10% or 8% is too low. I don't think we're ever going to get 100%. I'm a realist. Okay. So what's a reasonable split between the private sector and the state for readiness costs? I think it's, in my opinion, it's probably, you know, maybe 50%. Is it 40%? Is it 60%? Is it 50? You know, is that negotiable? Probably. Whatever we throw out is probably going to get negotiated at the Capitol. So what we were thinking, a 50% proposal would be about $5 million for a 1, 2.4 for a 2, 857,000 for a 3. Obviously, as surveys change over the years, these numbers would change because we want to tie this to the survey data. And you see, we're proposing 100% for the 4s because it's so low at 81,000. And we think this was our first time. And we know from doing previous surveys, our first time things were low. So we went up, we proposed to give them 100%. So the ask would be somewhere in the range of 60 million, 61 million, or half the readiness cost, in addition to what we're being funded now. We think that's a reasonable place to start. You might say, well, what about uncompensated care? Our general thought, and then this is a group discussion, so I'm anxious to hear what you think, because you're the guys that are going to have to use your lobbyists, and you're going to have to drive this, and you're going to have to be comfortable with what we walk out of this room with, not necessarily today, but as we work down this. You know, uncompensated care is a little messy. Readiness cost is a little easier. We have good data. We have good survey data. If we say we're going to pay 50% of readiness costs, we know what that is every year. If we say we're going to bring on another 1 or another 2 or another 3, or next year we're going to bring on 3 4s and 2 3s, we know exactly what the cost is. We can go back to the legislature and we can say, hey, with these centers are ready to go, they want to come into the system, this is what it's going to cost you. We need an increase in our funding to bring them on. That gives them a little authority and still power to say yes or no, or say, well, we've got enough in the coffers. We can bring 2 on this year. We can bring 3 on next year. So it is a bit of a partnership with them, still being able to have a say in how things are going. And it gives us a way to really streamline and ask in a way to show that we know what we're doing on bringing on additional centers. So that's sort of what the Stabilization Act offers. I just went over bullet number 1. It's a clean way of doing it. It also allows some of the money that we were using for readiness that we already had, that we could use for startup grants to help centers come on and to work in that arena. And then it increase in funding for rural centers, which was recommended by the American College of Surgeons when they came in. which minimizes the impact on ones and twos trauma centers. So I'm going to stop there. I'm sorry that took so long, but I felt like if we're going to have a team effort here in discussion, you needed to have good information, because from what I understand with my administrative team, they make good decisions when they have good information. So Michelle, I'm going to turn it back over to you, let you run the show here with the discussion, and just get people's feedback. Don't have all the answers, got a lot of information for you to talk about.
Great. Thank you, Dr. Ashley. And I learned something. I've seen this a couple times and I learned something each time he's gone through it. So I think when we really think about trauma, it's structure, process, and outcomes, right? So built a structure about 15, 16 years ago, processes have been defined, and now we're seeing the outcomes from that. And as administrators, I'd really like to hear, and I'm sure we'll send this PowerPoint out, would like to hear from you all on what your thoughts as it relates to both your individual systems as well as from the state level. We are very, very lowly compensated, obviously, for the care that is provided. And I know that from a healthcare system standpoint is a detractor for trauma. I know that it is hard to maintain. It is hard to keep up that level of commitment and readiness. And would like to hear from those of you on here any thoughts you have on the presentation today.
Hey, Michelle, this is Becky Weidler. I can kick us off.
Go ahead, please.
Yeah, thank you, Dr. Ashley, for the presentation. I found it very, very informative. A couple global questions. What sort of timeline are we looking at to get this presented to the legislature?
So now, you know, January is too late. That's when the session starts. The governor's budget will already come out here soon. So I think, Liz, you got the timeline in your head. You can jump in, but the sooner the better. If we can get this in the governor's, but this is just me talking. Okay, so I'm going to defer to the people that are much smarter than me in politics, i.e. the lobbyists and whoever else considers himself an expert. But if we get it in the budget, if we get it in the governor's, but that would be a home run. I don't know if this is possible because, you know, his budget will be coming out soon. But if we got it in the governor's budget, I think we have a tremendous chance to be successful, because I think we have enough data and we have enough friends in the legislature that they're not probably going to take that out. They might water it down some, but they probably wouldn't take it out. If we don't get it in the governor's budget and we have to get it in the House or the Senate budget and then go to committee, it can still work. It may work. It's a little bit harder. But either way, we need to come together as a hospital association and a trauma center association. An administrator group. Really, it starts with this group, because this core group of administrators, trauma system folks need to agree. Then pulse that out to, you know, GHA, and then we need to be talking very quickly to our legislators now behind closed doors, using all our contacts, and to where this has tremendous conversation well before we get into the January session. Liz, any comments on that to answer the question?
Becky, were you saying specific to, will we be ready for this session?
Yes.
Yeah, I don't know about that. We were able, thankfully, to float this out to a couple of government affairs folks for the level ones, and some of the feedback was that potentially, see, when Governor Kemp assumed office, the pandemic hit rarely in short fire. And so we haven't had the same level of access to really discuss trauma system needs with Governor Kemp. So we think that the guidance may be that we need to establish that connection first. And there are a lot of, there are very, shall we say, well-defined paths. So the governor's Office of Planning and Budget also has to be aware of this. So I'm not sure that we can bring it across the finish line for this upcoming session, but we do need to start working now to get ourselves plugged into the pathway to get it there across the finish line. And Dr. Ashley and I have talked about, getting his colleague, Dr. Joe Sam Robinson, who was on the commission at the outset of the commission, had some great initial data on, we've just skimmed the surface on the years of productive lives lost and what that means in terms of, contribution to the taxpayer base, essentially. Just trauma is a disease of the young. So it takes folks out in the middle of their most productive years. So we want to really kind of close the gap on that picture as well. And so those are just kind of some of my thoughts, but I think it's probably going to take a little bit longer than this upcoming session, because we're already almost, we're in August essentially, and OPB starts putting, the governor's recommendation that's released in January is probably already done at this point.
Great.
That was a great question though, Becky.
Thank you. Thank you for that information. Another question. Are there other system level projects or programs like this that are comparable to what Georgia Trauma Commission is asking for already in play in the state of Georgia?
Not that I'm aware of.
No, I'm thinking Becky as well. And I don't think related to healthcare and quality, there are a few related to outcomes that a number of institutions are involved in, Georgia Aid and a few others, but I don't know of anything of this magnitude that I'm aware of, but I'll ask around and see.
Okay, thank you. And then if not, I'm assuming that a way to tell a convincing story and to get the buy-in for any money, let alone the amount that's being proposed. Do we have strong partnerships with other statewide health equity focused groups or access to care groups in the state?
I think our go-to groups, I'll just take that real quick, and Dr. Ashley, you can jump in, but most of our, for these sorts of asks, historically, our go-to has been the government affairs folks from each of the designated centers, and then usually the Georgia Hospital Association. We've really established a great relationship, particularly with their rural health committee now, just because the needs of rural centers have grown over the years, and we need to grow more rural centers, obviously. So those are kind of the primary. Is there any others I'm forgetting, Dr. Ashley? And obviously there's Dr. Ashley mentioned there's a few legislators that have been very sympathetic to the trauma cause over the years, and a lot of legislators are physicians themselves.
Mm-hmm. Okay, great, thank you.
Any other questions? I'm just sensitive to time. We've got about 7 minutes left, so I want to make sure that we are able to answer any questions that you all have. Liz or Gabby, can we make sure this gets sent out to the group so they can, it's a lot, it's great, it's a ton of great information, but for folks to be able to process, we could probably add this as a follow-up agenda item for our meeting in October. And please, we don't have to wait for that to ask questions, but we'll definitely have it as an agenda item for our October folks. You may want to socialize this with your government relation folks. Like Liz said, we had a meeting the week of 4th of July with a number of GR folks from some of the institutions that are they gave us some guidance on some next steps. So I think it'd be appropriate as the senior executive for your teams to be able to socialize this within your institution and get some feedback. More eyes are always better than few. All right, just gonna quickly, because we don't have time to go into lots of discussion. We've had 2 trauma center diversion meetings in the last month. We had some deliverables or some folks that were out for the last meeting, so that didn't follow through. I sent out to the smaller group, both Georgia and multiple other states, diversion processes. You know, I've didn't get a ton of feedback on the diversion definition. Quite frankly, I think it's fine. I think it's how we operationalize it and what it looks like. So more to come on that. I'll be getting another meeting scheduled for that group, probably the middle of August. The second thing is Image Trend did go live on July 1st, really morely impacts those in the Atlanta metro region. It is it's the new GCC board that we did use during COVID and we will use for mass casualties, et cetera, through the state. If you haven't had a chance to take a look at that, or if you have any questions, please let me know. I know there was a ton of training that occurred the end of June around that. So it's up and running and we're able to move reports from it. The next step for that, we're just giving it some time to get settled. Any new IT system is looking at what that communication platform will look like. And we've seen this, we know that we need to do something around communication. So we're just waiting for that to get settled and more to come. So any other questions or thoughts from the group?
Michelle, I had a comment in relation to the presentation that Dr. Ashley gave. I thought it was excellent. I can't wait to dig into those slides more. One comment that I would make, I certainly understand the determination to err on the side of readiness as opposed to uncompensated care. But I would bring forward that, if politically the governor and our local government is not going to proceed with Medicaid expansion, then supporting uncompensated care for particular populations or subsets could be the way to go. So as we contemplate how we may tackle that uncompensated care portion, I think part of the conversation around that should be this could be an alternative to Medicaid expansion for, a vulnerable population. So I would just put that out there.
Agree. I do believe that, I think the Medicaid expansion is definitely a hot topic. We're only one of 10 states in the US that has not expanded Medicaid. So I think that's definitely going to be a hot topic this legislative session. And see where that goes. That would then impact this, obviously, from an uncompensated care perspective. And so I think that's where we'll look to Ryan and team's guidance on how we pursue this in tandem with that. So great points, Dr. Walker. All right, so Gabby's going to send the PowerPoint out. Tons of great information. It's so good, and it just looking at the outcomes. And I've ran that Whiskers data multiple times myself over the years, and it's always great to see the improvements that are being made to the commitments of the team and the commission. So I think that is all for now. We have our next meeting on October 23rd. If anybody has any questions or thoughts, please send them our way. But y'all have a great Monday.
Thanks, Michelle.
Thank you.
Thanks.
Thank you.